After 50 years of experiment in the deinstitutionalization of the seriously mentally ill and the closing of state hospitals across the nation, in the age of COVID and social media, we see images in the media of the mentally ill living out of cardboard boxes in the streets of LA or sprawled out in the subways of New York. Tragically, the seriously mentally ill now overpopulate state and local jails and prisons, an unintended consequence of what has been called the criminalization of mental illness, also dubbed trans-institutionalization. However, we encounter more commonly in our everyday life the seriously mentally ill who are in crisis, not so much in the jails or prisons of our nation, but in the emergency rooms and departments of our local hospitals. In hospital emergency departments, you will find them often in a confused mental state, psychotic and incapacitated, potentially posing a risk to themselves or occasionally even to others detained for that reason in the custody of a law enforcement officer. After a brief period of police custody, such at-risk individuals are too often removed from custody per state law, or to use the term more commonly employed, streeted, their mental status unchanged and left to fend for themselves on the street. If you are an ER physician on call in the ED on any given day, other risks may await you, such as that posed by the clinician in the Tarasoff versus the Regents of UCLA. Would you be able to identify an Adam Lanza from Sandy Hook or a Sung-Hui Cho from Virginia Tech who might be temporarily held in police custody, posing a risk to us all? Would you be able to diagnose accurately such an individual in an acute paranoid and delusional psychotic state, perhaps posing an imminent risk to self or others? Suicide and homicide are what psychologists and psychiatrists often term a low base rate event. High risk, low frequency events, which according to long-standing policies of both the American Psychiatric and the American Psychological Associations, cannot be predicted with reliability on the basis of current medical science and assessment practices. These are the challenges often facing emergency department medical personnel. We are privileged tonight to have a nationally recognized authority on mitigating medical risk who may be able to help us answer such questions and perhaps to gain greater insight into the workings of the mentally ill and occasionally criminally insane mind. Dr. Liebert is a psychiatrist in Scottsdale, Arizona, and is currently affiliated with the Banner Desert Medical Center. Dr. Liebert received his medical degree from McGill University Faculty of Medicine and has been in practice for more than 30 years. Dr. Liebert's primary interest and expertise is in the psychopathology and neuropathology of suicide and disorders of aggression. Based on these cases, he published Contributions of Psychiatry in the Investigation of Serial Murder in the International Journal of Offender Therapy and Comparative Criminology. His textbook, Suicide Mass Murders, a criminological study of why they kill, is a product of both his extensive clinical experience and studies of dangerousness to self and others. In his online continuing medical education course, Emergency Psychiatry for Non-Psychiatrists, Dr. Liebert has devised MPsych based on an accepted medical triage model and model of practice for the differential diagnosis and mitigation of risk for what Dr. Liebert calls unremitting states of human destructiveness to avoid confusing and conflating intertwined mental states of violence and suicide. Dr. Liebert is currently working on a new book that will address why children commit acts of violence. Dr. Liebert, we look forward to learning more from you based on experiences and narratives in some of these infamous forensic cases, and also to learn more how we as licensed and peer professionals may better learn how to mitigate risk through more effective triage strategies in the ER room, and perhaps to begin to do so as well in other community settings. Please welcome Dr. John Liebert.
Thank you very much, Dr. Creekmore. I'm honored to be asked to speak with you And as you know, you've got your work cut out for you, because the vast majority of this population,
When wise. Join the meeting.
the vast majority of this population in America, and I would include Canada, does not really believe that psychotic illness, whether it's serious mental illness, a bipolar disorder, or organic disorder, or schizophrenia, and we're talking, between them, at least 3% of the population. It's a lot of people. And of course, the vast majority of that population is not any more violent than their peers. So we have to be careful about statistics here. And I'm basing, my own opinion on the work of a classmate of mine at McGill, Dr. E. Fuller Torrey, who has spent his entire career studying schizophrenia in particular. And what he has found is that 6% of that 3% is more dangerous than the peers. 6% of 3% of 300 million is still a lot of people. So we don't have a system anymore to take care of them. Unfortunately, it's a whole other topic. But when John F. Kennedy was assassinated, there was no more support, for modern state hospitals and a system, and it just gradually collapsed. And I witnessed that. And Dr. Torrey's book, America's Psychosis, is an absolutely accurate month by month, year by year description of the process of how the system literally fell apart after Kennedy's assassination. The original title of his book was Rosemary's Baby, because it was his older sister Rosemary that was the spirit of inspiration for his work, along with his sister. When he was gone, there was no longer any adequate support at the state level. The states couldn't wait to get rid of this responsibility, and billions of dollars, went from the care of the mentally ill directly into the discretionary funding of the governor's office and departments of corrections. And when I say that you're courageous to be in this, because this is a real fight, because you're talking big money that has to be reversed and go back to where it was, many years ago. You can look at this through many different lenses. The Dangers of Untreated Psychosis. There's various theories: the pseudo commando, the contagiousness, sociological, a variety of things. My focus is diagnostic error, which assumes that all of these people that are committing mainly suicidal mass murders have been in treatment. Some of them have, and some of them haven't. Most have not, although they may have seen a doctor or a judge They didn't come out of the blue. They had a background. So something has happened. I got into this. I happened to be working at the time in the military, ironically, and it was the time of the surge in Iraq, not that long ago, 2007, 2008. And I was asked to write a book about the Virginia Tech massacre. To me, it was a one-off event. I like to write, and I do write, so I said, okay, I'll write a book about it. And I researched Cho and in Virginia Tech and that whole incident, along with the anthrax attacks that were associated with 9/11, which allegedly was a suicidal mass murder by a guy by the name of Bruce Ivins. That case was never cleared. It was closed for lack of leads, but most people think that it was solved. It wasn't really solved. There just weren't any leads beyond him after his suicide. So that was my first book, the Virginia Tech case. And then I was actually working parallel to Major Hassan, who was a psychiatrist at Fort Hood. We were actually doing the same thing. I did not know him, although the military psychiatrists I were working with, they knew, some of them knew him. This was, he did not bring down the United States government, but he brought down military psychiatry, that's for sure. Most of the psychiatrists I knew who were going to make a career of the military they left because the two top psychiatrists were forced to leave as a result of that, and everybody that was dependent upon them for rank, they just retired early. So he didn't destroy the army, he didn't destroy the country, but he sure destroyed military psychiatry. I don't know if it's ever going to recover. That was the next case, and I wrote about that in another book called Wounded Minds, along with the massacre in Afghanistan by Sergeant Bales, who was a patient in the clinic I was in, although I did not have him as a patient. Again, he, like many of these individuals, too many of them, I should say, they're certainly not the majority, but they're in this mix. They are veterans, and they're declared fit for duty, and they're discharged oftentimes with what's called a general discharge under honorable conditions, which means they don't get any benefits. They're just showed to the gate, and goodbye. It's not dishonorable, it's general, but they don't have any benefits. And they're in that homeless population, and a lot of them are very sick. Sergeant Bales was one of them, and instead of discharging him, they sent him to Afghanistan. He already had like half his foot blown off, and he massacred all those people in the village, and then just collapsed on the ground, which to me was suicidal. Somebody found him and saved his life. And so what's left of military psychiatry back then is he's Major Hassan's barber now in Leavenworth. That's kind of interesting. So the dangers of the untreated psychosis, I feel like I got into this by, walking down the street in London in the medieval times and stepping on a body and not knowing what it was. And writing about it, and all of a sudden, you got the plague, because whatever the causation, whatever anybody's opinion is, there's no question about it. It might be an infrequent event, but it's absolutely soared in incidence and prevalence. And most of these individuals, from what I've been able to determine, even if they don't have a record of psychiatric treatment, are psychotic and suicidal. So why now? I don't know. Is it guns? Guns have always been here, but I have no explanation. Okay, let's go to the next slide. All right, so looking at this from the point of view of misdiagnosis, misdiagnosis is one of the commonest causes of, one of the most common causes of death and total disability in the United States, in America. Canada, I don't think, is much better than we are. But so I say Canada, I say America, and I include Canada, which is a modern system, but it's different than our system. And I'm not talking about medical errors, because that's another common cause of death and major disability. That would be, for example, in the course of a surgical procedure, there's an artery that's mistakenly cut and the person has a huge hemorrhage. That's a medical error. That's another big problem. I'm talking about misdiagnosis. So the one thing in common about these people is, if they had any contact with physicians, clinicians, they obviously were not diagnosed. The best example is Adam Lanza. He went to one of the richest and best resourced child development center in his mid-teens, because he was behaving strangely. And he came in with a diagnosis of autistic spectrum, which was kept. And he had a 3-hour evaluation, extensive evaluation. But if you read about that extensive evaluation, the psychiatrist, the professor, said, I saw him briefly. So that means to me, in my experience, he might have seen him for 15 minutes and then turned the patient over to the nurse practitioner. And this was, a long time ago. Some of these nurse practitioners were well trained, some of them weren't. And she medicated him and started him on an SSRI antidepressant, probably because of the diagnosis of obsessive compulsive disorder, which was the main expertise of the psychiatrist that he saw at this facility. And the mother complained that he wasn't tolerating the medication, and she encouraged the mother to keep him on it. Well, it turned out that Adam Lanza was psychotic and needed to be on an antipsychotic medication. At least he needed to be evaluated for that. He didn't have any testing, and I've talked to Dr. Creekmore about that, and I think that he, at the facility where he was, they could have done anything. They could have been brought in the best of psychologists to adjust projective testing to that age group. He could have had an MMPI, and I think the writing would have been on the wall. But instead, he was sent home on a Lexapro, which is similar to Prozac, and he got worse. The mother took him off it. The mother was basically held responsible for causing the problem. He never went back. They didn't check with the school, and they didn't come to his home, because had they come to the home, they would have found that he lived in the basement by himself. He had no communications with anybody, and he had broken off from his father, his brother. He communicated with his mother upstairs via email. And of great interest to me is that he had a stack of newspapers called the Norway Times in English. And he and I shared probably the only stack of this paper, because, you know, we were both I didn't know him, and he didn't know me, but we were both following the case of Anders Breivik in Norway. He was the guy who called himself the Commander Breivik, and had this huge underground network all over Europe, and went to Ataya Island off the coast of Norway, and just slaughtered these kids on the island, and literally the sea turned red, and he's, unfortunately, he pleaded sane, whereas he was prosecuted as being insane, and he won. So he went to prison. Well, little does anyone know that in Norway, you can only keep a person in prison for 20 years, regardless of what he did. So he's going to be coming up for release, because he was declared, he won his case, and proved that he was sane. And of course, now they're going to have to find him insane, or he's going to be cut loose. I don't think that's going to happen. But we were both reading about Anders Breivik. So this is not an autistic child, Asperger's disease. He was very careful in planning this attack. And of course, there's a big mystery. Why did he kill his mother? Was it what he was matricidal? What was the matricidal issue? And he was strange behavior. He was walking down the hallways of his high school, clutching a computer with his back against the lockers. Now, in all of these protocols in what you're looking at come from my programming of what's called the digital clinician for triage, which is a training tool for triage, but they're not my protocols. They're based on, it's presentation based. In other words, there's certain presentations like chest pain, like collapsing, like strange behavior, intoxication, or appears drunk, history of mental illness. Those are 3 presentations, equally weighted, along with like chest pain, and hemorrhage, abdominal pain, etc. And it's what's called presentation based. And what I'm trying to do here, the uphill battle that you all know, I'm trying to, make people aware that the occasional encounter that you might have with an individual like this, you need to follow the rules. You can't just fly by the seat of your pants, like happened at this famous institution that released them on what I think was the wrong medication without really adequately going into it. And to this day, the state of Connecticut, University of Connecticut Medical School, et cetera, I mean, they seem to be more interested in protecting the interests of this evaluation. And they protested too much. There's no evidence of psychosis, no evidence of psychosis. He was not psychotic. Well, you can say it once, or you can say, well, we didn't think he was psychotic, but 5 times. And, don't criticize your colleagues across the state. They did a great job. Well, I don't think they knew what they were dealing with at the time. It was a brief interview on a 3-hour workup, no psychological testing, no home visit, no discussion with the teachers. It was not the child psychiatry and adolescent psychiatry that I was taught in my residency training. We went to the schools and we did home visits, and all they would have had to do is do the psychological testing, go to his home, go to the school, and they would have realized this is much more than Asperger's with obsessive compulsive. So go to the next. And you can see down there forensic issues and emergency psychiatry. Go to the next slide. Okay. Very briefly, I mean, this is, a whole discussion in itself. Tarasov, you're probably familiar with it. What is it? It's the duty to warn victim. In this particular case, University of California Mental Health Center in Berkeley. A gentleman came in and literally told the psychologist, I've had it with her. She's, I'm going to kill her. I mean, he basically made it quite clear that he was going after Tanya Tarasov. And so the psychologist and all, he took it upstairs and discussed it with the administration and the psychiatrist, et cetera. And they decided this would be a violation of the patient's confidentiality. And the patient went out and killed Tanya Tarasov. I just happened to be at a forensic psychiatry meeting shortly thereafter, and the Supreme Court judge from California was there, and he explained. He says, why did I rule, in favor of, the Tarasovs, and why do you have the Tarasov decision? It's just a matter of common sense. That's what he said. So, and perhaps it is, but that's what we have today. Some states have more specific. Here in Arizona, we have Hammond, which is, much tighter. But Tarasov, even though it's California law, I mean, it's there's a psychiatrist, getting sued because his patient, whom he hadn't seen in months, killed somebody. And he's being sued, for failure to warn the victim. So I call it Tarasov and progeny. The state of Washington case up in Spokane is progeny, because I actually did it Tarasov in California, and that's real life. We had 3 or 4 clinicians assigned to this individual. Tragically, we were so focused on the potential victim when he was discharged that we missed that he had other issues, and he eventually did kill somebody. That he didn't kill his girlfriend, he killed somebody else. Again, I think that was a diagnostic error, but so just continue on. This is I don't want to get hung up with Tarasov. Next slide. So what is triage? Triage is time-determined clinical decision-making, because all presentations are divided based on safe time for intervention and clinical intervention. Sometimes you have no time, and sometimes you have plenty of time. Depends on the presentation, but you have to make that decision. Is this an emergency? You've got no time. Epidemiologically informed means, what is the likelihood that this person could be suffering from this? I obviously I did this during the hurricane in New Orleans. So at that particular time, the main hospital down there, Charity Hospital, was flooded and patients were drowning. So, your site is informed by the knowledge of floodwaters. A simple case, I've been back and forth, working in Seattle and in Phoenix. So if you're a gardener, and you're working smart, in Seattle, you can put your hands in the dirt and you're very unlikely, to get bitten by anything poisonous. Very, very unlikely. In my backyard, you do that, and eventually you're going to get nailed by a rattlesnake. So it's just a simple matter of working smart. There are no rattlesnakes in Seattle, but there are a lot of rattlesnakes in Arizona. And that's just a simple way of saying that you have to be epidemiologically informed. Let's go on to the next slide. Okay, this is another I guess tragic opportunity that I had. This is the Paul Keller arson case, the largest solved arson case in American history. At the time, I don't know about now. That doesn't mean it's the largest arson case. Arson just happens to be very difficult to solve, but this case was solved, and it's called Paul Keller. He burned numerous buildings throughout the state of Washington, including at the end a nursing home, and killed some people in the nursing home. And this is just what we do or should do, and the longitudinal history of his life. And he turned out to be come from a fairly high level family in a place called Everett, Washington. Was born a blue baby because his umbilical cord was wrapped around his neck at birth. He was a blue baby, and the parents made enough noise about this that the judge wanted him to be worked up absolutely thoroughly, particularly concerned about brain damage. and I was able to hire any consultant that I wanted. So I had an expert psychologist for projective testing. I had an expert psychologist for neuropsychological testing. I had a neurologist who was also a psychiatrist, a neuropsychiatrist, do his, physical exam looking for soft signs, because interestingly enough, he was diagnosed with attention deficit disorder very early and at the University of Washington, and pretty early diagnosis. So, this guy had a history. Unfortunately, he was aware he was coming apart at the seams. In 1992, he was born in 66, in 1992. I'm talking about he's going on 30 years old. He goes to a neurologist, doesn't keep his appointment. They didn't follow up on that. But then he goes to a mental health center. He knows he's coming apart at the seams. And his testing showed what we call, well, I don't know about Dr. Creekmore, what we used to call, emotional bankruptcy, a declaration of emotional bankruptcy. Unfortunately, they didn't interpret it in terms of psychopathology, which was clear. They interpreted it in terms of nutrition, and they put him on a diet, which is not what he needed. And but he was, all credit to him. He at least went in. He knew he was coming apart at the seams. And the black line is marijuana, and then he started drinking on top of the marijuana. And then he went bankrupt. You can see that. And that's when the fire started. That's the thick line fire setting. Started right after his bankruptcy, the trauma of his bankruptcy. Okay, next slide. And this is the triage algorithm that I developed as a result of Paul Keller, that you have to be able to move around within the psychopathology. So you might be down here because he was having marital problems, and you might be down here in adjustment disorder because he was having current adjustment problems. But if you stayed there and you didn't go up here, you were going to miss everything, because you had to go back and forth through this. He had neuropsychiatric. He had addiction history, addictiveness, and many other things. So we have to be able to, move around logically, following the rules of triage. Next slide. Okay, so this translates into the program that I developed for training purposes. Red is, immediate, no time. Orange, you got 10 minutes. Yellow, you got an hour. Green, you got 2 hours. Blue, you got 4 hours plus. Okay, low acuity, etc. None of this is mine. This is, the evidence-based literature. And so when you're seeing these people, and somebody saw most of these people, Cho, for example, as soon as he got to Virginia Tech, he had believed that he was infested with worms, and he went to a family doctor in Virginia, Western Virginia, which is pretty rural, probably not highly, high density of physicians. And he was diagnosed with acne. And he kind of patted on the back. Don't worry about it. Here's some lotion for your acne. Well, he didn't have any acne. But of interest is that he never forgot that. The morning of the morning of the massacre at Virginia Tech, he was observed by his dorm mates putting this lotion on his face. So that diagnosis stuck with him because he was grossly psychotic. Unfortunately, he was committed for, threatening suicide. And he had 36 hours hold, but he only stayed for 1 day. He had 72 hours and he stayed for 24 hours. And the psychologist testified that he saw him for 15 minutes, and the psychiatrist said, I talked to him for 15 minutes, total of 1/2 hour of evaluation. And he wouldn't talk. So they decided that he had selective mutism. He wouldn't talk, so they discharged him. Fortunately, it didn't turn out too well, but the hearing officer went against medical advice, which was quite interesting, and committed him against medical advice. And he forced him to make an appointment at the Cook Counseling Center at Virginia Tech. Unfortunately, their psychiatrist had just quit or taken leave, and so there was nobody to prescribe medication at this clinic at that time. He kept his appointment. Nobody has any idea how he got from the hospital back to Virginia Tech, but he did get back, and he kept his appointment. The medical records disappeared, and I thought they had been deep sixed, but eventually they resurfaced, and the director said, oh, I just picked them up by mistake. But anyways, he was obviously psychotic. There was a famous poet, teacher of his, who said, he took off his sunglasses. I looked in his eyes. I couldn't see anything. The students said, this guy's going to kill somebody, and he had a history of, he was seeing a child psychiatrist at Georgetown, I believe it was. And he was talking about Columbine in middle school. He was obsessed with Columbine. Nobody thought he should go to Virginia Tech. They thought he should stay closer to home in the Virginia area, I think where you guys are. But he wanted to go to Virginia Tech, so he did. The parents found out about his killing just the way you and I did on television with his manifesto, and they didn't speak very good English. They were from Korean, but they were very, very smart, and they had the means, and they said, my God, why didn't they call us? We would have just come up, picked them up, and we would have taken him back to a psychiatrist. So again, a lot of this stuff gets lost in these conferences, and there was a big investigation. The only problem is that they didn't invite anybody from the medical community, to this investigation. And the Virginia Psychiatric Association, the Virginia Emergency Medicine Association, the Virginia Medical Association, they all complained, said, you guys didn't invite any of us. Said, well, we had a psychiatrist from Virginia VCU there, and we thought you guys talked to each other, so we didn't think we had to bring everybody in. So we just had the psychiatrist from VCU. Well, the psychiatrist from VCU, I heard that, that she wasn't too impressed with that case, but no way would she go public. So they were pretty protected. It did end up in a lawsuit, and with major punitive damages. But ultimately, the Commonwealth of Virginia prevailed with immunity. So two of the family members refused to settle with the Commonwealth and filed a lawsuit, and they won. But I don't think they ever got paid because of the Commonwealth had immunity. So, and this is a misdiagnosis, and the psychiatrist and the psychologist, they testified, and they said, well, he wouldn't talk. So, we're pretty busy, and so we spent 15 minutes each. And what we call, high velocity, typical of working in a big county hospital, particularly in California, a quick evaluation that's worthless. Next slide. Okay, so in the red zone, I don't want to spend a lot of time here because this isn't really about emergent psychiatry, but and if you have a better mnemonic, please let me know and I'll pay you, because this is silly, but I picked it up and put it together from the different places I've worked. Triage is as easy as A, B, C, D, E. If I throw out the guns, act myself, and then eat Ma's taco salad. All right. You just have to remember, triage is as easy as A, B, C, D, E. If I throw out the guns and act myself, in the emergency in the red zone, you don't have time to follow the rules. And the guns include any kind of weapon, particularly a chair. If a patient says, I don't want to talk to you, you don't talk to him, leave. And this was the Brian Buss case up in Oregon, which is an annual memorial to him because the patient didn't want to talk to Dr. Buss, and Dr. Buss insisted on talking to him, and the patient hit him over the head with a chair and killed him. And this is not uncommon. If the patient says, I don't want to talk to you, you go, you leave. So guns and weapons, it doesn't have to be a gun, although more commonly it is now in the hospitals. Using drugs, I'll look for needle marks, need to protect from situation outside. There are facilities, I've worked in one in Salinas, California, where there's a lot of gang violence, and a potential victim who's being chased by a gang will come in to the hospital for protection, and he'll look kind of strange, arrogant, because he's not looking for help. He's trying to, get away from the gang and need to protect from situation outside. And you see later that we actually had continuing medical education on gang violence on the grounds of the campus of the hospital. Next slide. Is the presentation appropriate? Here's got an unresponsive child. Is an unresponsive child, and the parents are hovering, over the emergency room table and show no emotion. Well, that's not an appropriate presentation. The appropriate presentation would be for the parents to be obviously, very distraught. Okay. And I already had one case like this in a rural area where a mother brought this 7-year-old boy in for a routine checkup. I had him on attention deficit disorder medication, Ritalin, I believe. and she brought him in, and he had a scalp like mine. Obviously, he lost his hair, but on top of that, it was all red and a huge abrasion on his scalp. And I said, "Oh, by the way, what happened?" She says, "Well, a fan fell on him." And I said, when did that happen? 2 weeks ago. She was unconcerned, I mean, and nothing to worry about. He's fine, and the medications are working fine. Well, I decided that I think it's best, even though it's 2 weeks ago, to go to the emergency room. She said, "Okay, I'll take him to the emergency room." She did. The emergency room called me back. The doctor was furious. Says, "What the hell are you sending?" That's the way they talk up there. "What the hell are you sending this kid over here? This happened 2 weeks ago." And I said, "What do you think it was?" And he says, "A fan fell off the ceiling and gave him a haircut and an abrasion of his scalp." And I said, "Are you sure?" And he says, "Yeah." And I said, "Well, thank you very much." He says, and then he cooled off and said, "Oh, I see what you're getting at, and all's well that ends well." In next slide. These are altered states of consciousness that'll kill you immediately. You just have to know these. They're called the WIMPs. And there's a difference between an intracerebral bleed and a subdural hematoma. If you remember the case of Natasha Richardson, who fell on the bunny slope up in Tremblant, north of Montreal, and died. She had an intracerebral bleed, but it was an arterial bleed. That's an immediate emergency. Instead of taking her into the emergency room, which was 1/2 hour away, and they had a CAT scan and scanning her, and they could have decompressed it. They just put her in a different ambulance, and they sent her back to New York, and she died. She didn't have a concussion. She had an arterial subarachnoid hemorrhage. Now, subdural, as you know later, the venous bleed can wait, longer, but an arterial bleed is an immediate emergency. Next slide. This is called the CDC coma, confusion, dementia complex of altered states of consciousness. I just processed eye problem throughout this expert system because eye problems are pretty easy compared to like abdominal wounds, and I did it just out of ease. There's only one real emergency. Next slide. Chemical eye injury, that is an immediate emergency. If you don't handle that, just right and wash that eye out without it running into the other eye, this person's going to be blind. But this is just an example of going through a presentation eye problem all the way through from emergency to the blue zone where you got plenty of time to work it up. Next slide. Okay, now this is, if you take anything away, this is probably the one you really want for this session. Okay, and as I said, the mnemonic, as silly as it is triage is as easy as A, B, C, D, E. If I threw out the WIMPs, you saw those altered states of consciousness that'll kill you immediately, like Natasha Richardson died. And also throw out the guns, make sure that that patient isn't going to harm you. Emergency rooms, by the way, are the second most dangerous work site in America. Second, their only mining is more dangerous than working in an emergency room. So you need to know, whatever mnemonic you need, but you need to be able to screen people quickly. But as far as this session is concerned, this is what you need to know, Ma's taco salad. So if you just take this away from this presentation, I think, you can start making some progress and help others start making some progress. Because if you look at all these individuals, the Mandalay suicidal mass murderer, Stephen Paddock, he saw a doctor right before he did it. The doctor gave him Librium, a benzodiazepine. Talk about acting strange. He was like a Howard Hughes. He had, wore rubber gloves because he had this germ phobia. His girlfriend couldn't have perfume. I mean, he was obviously paralyzed with phobia. He had a strong history of bipolar disorder in his family. And talk about strange. He was bringing boxes, up the elevator to his room in the Mandalay Bay. Well, that was ammunition and weapons for reloading. That's pretty strange behavior. So you have, the present patient, strange behavior, and he went to the doctor right before he did it. Now, there's 3 letters missing, and that's Ma's taco salad. Again, if you come up with a better word, let me know. M is for medical. Did he have a medical condition? We don't know very much about this guy because it's pretty closed mouth up in Las Vegas. I don't think he did have a medical condition, but a guy who's 55 years old, diabetes, cardiac bypass surgery, and having amputation of his toes. That's pretty debilitating medical history and a suicide risk. So this is your mnemonic for suicidality. So M is medical, A is attempts. We've all had these. I lost a guy, a few years ago. It was awful. He kept attempting suicide. He'd go in, he'd stay for 36 hours, get released, and he had a gun in his backyard. He said, "I've got a gun in my backyard," and I there's just nothing I could do that I knew of, and I knew this guy was probably going to do it eventually, and because he had attempted before. Jumps off a bridge, takes a dive off a bridge. I wasn't expecting that. And so previous attempts are the best predictor of future suicides. C is for culture of violence. if you have the schizophrenic patient doesn't necessarily have a family history. It's not as robustly genetic as bipolar disorder, and bipolars do commit suicidal mass murder, particularly when they're in a mixed state of high energy and depressed, so culture of violence, is there a history of, violent suicides in this family, a family history? Oh yeah, I mean, both of my uncles hung themselves. That's a culture of violence. In the case of Adam Lanza, why did he have those guns? Why did he have skills with weapons? Well, his mother grew up in a rural area of New Hampshire, and the family hunted, and she believed that a boy should know how to hunt. So she trained him. Most of these guys, learn on the internet or go for training, but not Adam Lanza. His mother taught him. And she was not careful with the guns. She provided her own murder weapon to her son. Which goes to the O, which is organization, mental organization. So why did Adam Lanza, why did he do this? Why did he have all these problems in high school, walking down with his back to the wall, clutching a computer, living in the basement, communicating with his mother by, and then he goes and kills 26 people, including himself. I lose track of the numbers. I think it's 26 total, including himself and the teachers and the first graders. And first of all, he kills his mother. Why the matricide? Followed by the suicidal mass murder of first graders. He was actually going to a college. Why didn't he? And he had dropped out of another college. Why didn't he go to the college? Well, we'll never know, will we? Because it was delusion. It was a delusion. And his mother might have gotten wind of that delusion. She was talking to her friends, and she was making plans to take him to Washington State. That's 3,000 miles the other side. Probably, I think, to a very safe juvenile facility, private. She had $385,000 of alimony, so she could afford it along with insurance. So she could afford to put him in this very expensive island in the San Juans of Washington. And she was talking to her friends, and he probably picking up that hey, I'm going to be locked up, and he was going to be locked up, I think. So that might have been a motivation for the matricide. She might have become aware of his delusion, but we don't know. Okay, then we get to the S, and that's support. Back to, do these people that have done this, we look at their lives, do they have support? Social support. Most of them are pretty much loners. Adam Lanza lived in the basement, had no contact with his family. People would visit the house and say, Jesus, he lives down in the basement, weird. Cut off all relations with his family, communicated with his mother. He had no support. Nancy wasn't able to do anything for him in the way of support. she tried, the experts in Connecticut said that they blame it all on her, that she should have followed the doctor's orders, and she wouldn't get him the kind of treatment that he needed, etc. The fact is, we'll never know. But he certainly had the resources. He was at one of the best child development centers in the country, and all the resources were there. So support, lack of support is another indicator for suicide. Alone, living alone. Well, he lived alone. Even though his mother lived on the second floor, he lived in the basement. He was totally alone. Loss, very important. And I missed another one. S for separation. That's another factor. So it's separation and lack of support. Houghton of the Azuna Spa suicidal mass murder in Milwaukee. He was separated from his wife, and there was a long history of domestic violence. The police were in that house every week, but eventually she separated. She was a beautician, so he goes to the beauty shop, mows everybody down, the clients as well as the beauticians, and took his wife out, and then he took himself. That's a Zuna Spa murder. And that took place very close to the Sikh temple murder in Milwaukee. You might remember that. Loss is extremely important. I think it was not just separation, but it was loss that set him off. And I think that if we ever find out anything about Paddock in Las Vegas, as to why he did what he did, he probably was losing money. He was known to be the only guy that beat the house in Las Vegas. And I'm not a big believer in that. I don't think you could beat the house in Las Vegas, and I don't think he beat the house in Las Vegas. We don't know, but I think he was losing money, and that would be enough to trigger a guy like that, who won at the blackjack table of fortune. Alcohol and drugs, I think, obviously, that's disinhibiting. The classic case is Wade Page, who was treated for alcoholism in the military. Well, he had more than alcoholism. He actually, a very, very intelligent guy. He was with military intelligence in Berlin. He actually goose-stepped down Kurfürstendamm, which is the main street in Berlin, which is against the law in Germany. And he was drunk. And I don't think he ever stopped drinking, although the military did send him to a facility, cleared him, for alcoholism. But he, I don't think he ever stopped. So alcohol and drugs are very important. The case of Robert Card up in Maine. Is that Bristol, Maine? Can't remember. But the guy in the military reserves who went to the bowling alley and the restaurant and mowed down all those people fairly recently. I think he was probably intoxicated. And actually, his autopsy just came back on his. Thank you, Lewiston, Maine. Thank you. They did a brain section on him and an autopsy. It came back positive. He had severe brain damage, but it wasn't probably from alcohol, drugs. It was from being a hand grenade instructor and being exposed to repeated traumas from the hand grenades. Really severe damage. So there you go. You know, I mean, not all these people are functional psychosis from bipolar or schizophrenia. And so these are again, just as a reminder, these are the presentation basis. Strange behavior. Everybody I've mentioned today was behaving strangely. And that's a presentation, not mine, that's, you know, from the books. Appears drunk. Wade Page, probably Robert Card up in Maine. They probably, you know, appeared intoxicated, although in the case of Card in Maine, you have to remember he was a petroleum specialist. Well, I've been in the military, you know, but I wonder, what does a petroleum specialist do? What's he exposed to? You know, I mean, I have seen individuals who become very paranoid in occupational settings when the air conditioning goes down or the ventilation's bad. And they get very paranoid, and they're capable of harming people. So he could have been toxic. He certainly was brain damaged. We know that. So he's a different type of suicidal mass murderer than the others. Self-harm, you know, again, I mean, which one of these major suicidal mass murderers, including he, you know, from Nashville, who went to the Covenant School and killed all those people, and then the police shot her, him, her. She was allegedly transgender, and she was, you know, suicidal, and she wrote a suicide note. She also wrote a manifesto. We don't have access to it, that I don't think. History of a psych problem. Certainly Stephen Paddock, the Mandalay Bay. He had a history of a psych problem. The Steve Kazmierczak, who did the NIU massacre, was committed in high school in Chicago, and he was treated with Clozaril, which was the heaviest duty antipsychotic we have. Somehow he was able to get out. He made 3 extremely high lethality suicide attempts, and was able to get into the military, get into advanced infantry training. He washed out of that, but he was hired by the state of Indiana and for corrections, and taught how to use a shotgun. So he was really well trained with weapons. Now, he did pretty well at Northern Illinois University, but he had to drop out. He wasn't able to do the work in the graduate school at Northern Illinois University. So he went to the University of Illinois in the southern part of the state. And he got on some kind of chat line with NIU and was getting more and more preoccupied with homosexuality and inappropriate stuff. He went to a doctor and who put him on a benzodiazepine, because this doctor didn't know that this individual had been committed in Chicago, and also had what appeared to be the triad. He was known to have been cruel to animals and set some fires. We just don't know if he had enuresis to complete that triad, but there's a guy that had a very, very robust psychiatric history. Next slide. Again, I'm just following through. We're in the yellow zone, and you progress. These are the presentation of eye problem, and these are the diseases that you have to treat within an hour. Next slide. And if you remember that, that diagram with Keller, the arsonist, where I encourage you to, don't get hung up and anchored in one of those squares. Always be willing, always be ready to move up to a more serious condition. Like with Paul Keller, the arsonist, that wasn't a nutritional case. That was a very severely disturbing MMPI in a guy that was basically emotionally bankrupt. So be ready to, to move up. There was no mention of his alcoholism, his addiction. So, don't get anchored in a diagnosis like happened with Adam Lanza. They got anchored with this diagnosis, and and if you go to a conference in Connecticut, I guarantee you, they will jump on you if you say that he was psychotic. So always be ready to push the reassessment button, because you might be wrong, and better wrong and alive, so reassess. I don't know about the rest of you, but I don't always get it right the first time. Next slide. And so just as a reminder, select the rules and treatment protocols for triage. Next slide. Now you're in the green zone. This is high acuity. You got a lot of time here. You got 2 hours. And 2 hours, you should be able to figure out if a person is, more likely than not, high risk. Remember, you're predicting, and the probable cause is in clinical evidence is more likely than not. Now, if they survive and they go to court, we've got a guy right now up there in Idaho who's going to go on trial. We don't know very much about it, and innocent until proven guilty, but the case against him looks pretty powerful for him stabbing 4 people and having a reason to do it, having studied Ted Bundy from the same state, who slaughtered all those girls in the Cuyahoga house down in Florida. And my theory is, he was probably trying to beat Bundy and get away with it. Bundy didn't get away with it. That was his last stand. He was arrested after that. He killed one more after that. So this is the time when you have plenty of time, and you can get some basic testing on these individuals, and find out what's going on with them. There's plenty of time, with Koberger, in Moscow, Idaho, to find out what was going on with him. Of course, we don't know that because that, you know, that case is shut down. Nobody can talk about it. Next slide. You get to the blue zone, and here I've included in the blue zone of the digital clinician, I've included the testing that was developed by Caton at the University of Washington. It was brilliant to separate the psychiatric patient from the medical surgical patient. He studied the population of group health, which is part of Kaiser, very large general family practice population, and found that 10% of the members of this particular HMO utilized 90% of family medicine services. One half of that high utilization group were pure psychiatric patients. The other half had very serious illness, terminally ill, etc. But a very large percentage, like 45% of the family practice, was pure psychiatric. And so he developed this system to pick these people up and get the psychiatric patients into the psychiatric clinic, so the family practitioner can work with the people who really needed medical surgical attention. Unfortunately, insurance wouldn't pay for it. The University of Washington shut down the program. The only good news for me is that they said, yeah, why don't you work on it? So you're looking at the blue zone, and in the actual expert system online, www.digitalclinician.org, you get to the blue zone and you see the testing that Caton et al. Developed to separate the psychosomatic patient from the true medical surgical patient. Next slide. Okay, and then this is basically just a summary. Embed your experience within the rules for triage, such as knowing whom to see when and for how long. Might seem obvious, but the trend is the opposite. You want an empty waiting room. You don't want to keep people waiting because they might be dissatisfied with waiting, and your reimbursement might be cut because of dissatisfaction with the Obamacare. So if you want to talk about your emergency room in today's environment, you want to show, look at this emergency room, it's empty. And I don't think that's good. Embed your knowledge into the what to do then, or clean protocols. Save the patient, but then quickly attend to yourself and others affected. I saw an article I think it was yesterday, that this poor individual, this poor man was, kicked in the testicles by a patient, and he died. This was fairly recent. I don't know where it was, but hospitals are, not a sanctuary anymore. Next slide. So you have to rule out those organic brain syndromes and get them on a neurological clinical pathway. Robert Card up there in Maine was in a psychiatric hospital for 2 weeks, not long before he committed this. And he had severe, brain damage, and he was just discharged. It didn't appear like he was discharged for neurological or neuropsychiatric follow-up, is just discharged. Now, in the general population, of course, that's understandable. You don't have that much control. But this guy was on active duty at the time in the military. And so on paper, he was considered fit for duty. And he has glowing reports from the military. So that gets into a whole other area of military discharges, which need to be looked at. Nobody wants to do the medical evaluations, the MEBs, and so consequently, there are too many of these guys that are, really sick and potentially dangerous, like Wade Page, like the Navy shipyard shooter who got an honorable discharge. He was grossly psychotic. He believed, and he talked about it. He complained about it. I have a chip in my, I take this chip out of my brain. And he was discharged with an honorable discharge. He went from Veterans Hospital to Veterans Hospital on the way down to Washington, D.C. and saying, you got to get this chip out of my brain. And they gave him some medication to help him sleep. And eventually he just blazoned in the butt of his rifle, the name of this particular chip that was in his brain, and the rest is history. And all those people got killed at the naval shipyard. Prevent harm to self and others with least restrictive treatment. Well, we're pretty much there. You need to take care of yourself, because I don't mean to be cynical, but if you're working in these high acuity situations, clinically, you need to take care of yourself. All of us, I believe, that have been in these high acuity situations have been assaulted. I have, and I've been very lucky. I had no idea. There was a guy watching television in a county hospital in California, and I just stopped behind him and looked at the news, and then I was only there for just a matter of seconds, and all of a sudden he was coming at me, and the fight was on. So you need to know how to protect yourself. And there's a stance where you stand sideways with an exit. You need to know who's there. I mean, in this particular case, I should have known that he was on that ward because he was totally harmless in appearance. But I got into his paranoid zone and I almost got killed. Okay, so you need to take care of yourself, because nobody else is going to take care of you in this day and age with the types of patients that are being treated in the community, who should really be at a higher level of care. Next. And the mechanism of injury, we discussed that, with the boy who got the haircut from the fan. What is the mechanism of injury? That's important. Next. Sniff the air, with this individual card who was, around all these chemicals. Did anybody notice any odor? These are the way you can smell. And it does happen in occupational settings, depending on where you, particularly at cheese factories. I've worked in communities with cheese factories, and they don't have good ventilation, and they can be quite odorific. But also sniffing the air means, use your sense. So when you're sitting with that patient with the triad I mentioned before, and your knuckles are going white because he's dehumanized, that's important. You're sensing, you're sniffing the air, and you have a homicidal patient that you're talking to. Pay attention to it. Don't ignore it. You're probably right. Next. These are just infections that are contagious that you have to rule out. And I don't want to spend too much time, but you have to remember that this guy from Uganda came to Dallas Presbyterian Hospital, and he had 104 temperature, was non-ambulatory, and the alarms were going off with the electronic medical record, and it was just so much noise that they just sort of lost track of what was going on with this guy, and they discharged him back to his girlfriend, who took him home. He had Ebola, and this was the beginning of the Ebola epidemic. We didn't have Ebola at the time, and you know, the nursing staff that was exposed to him had to be taken, I believe, to Nebraska for specialized treatment. So, I mean, you need to know, you know, what these are. Next. And these are the important statistics of being epidemiologically informed. The number 5 cause of pediatric mortality, 1 children a year, is child abuse. 70% of child abuse victims, when they have children, will be abused if not treated. You just need to know that. Elder abuse kills 500,000 patients. You have to really be aware of that. When you see a person from a nursing home and they've got a black eye and all bruised up, you know, you particularly if they're coming cared for at home, you know, you need to think about elder abuse. And this is important here. There are not very many studies like this. So when you can find something, you know, I mean, use it. 128 of 1,000 consecutive ER visits are danger to self. Only 6 out of 1,000 are purely DTO. That's why I combine this into unremitting states of human destructiveness, because, you know, I think to try to separate the suicidal patient from the homicidal patient, particularly when we're talking about mass murder, is a very dangerous exercise, because that, to me, means that you can't really tell. They're more likely than not both. And, you know, the rate of mortality from violence, 1/6 the rate of accidents, that's high. 1/2 the rate of suicide, which is a top, I think, number 8 cause of death. It's like, you know, up there in, you know, in the teens, it's high. And like the Houghton case in Azuna Spa murder in Milwaukee, the second leading cause of death for women in the workplace is homicide. And that's not true of males, but it is true of females. So the domestic violence victim is not safe by going to work. She might think she's safe, but she's not safe. And an interesting study showed that most domestic violence cases are preceded by verbal threats and aggression and arguments, and Interesting. Probably not surprising. Male clinicians tend to pick it up on the third visit. Female clinicians tend to pick it up on the first. And so you can't just, minimize the couple who's having a fight, because one of them might come back dead later on, usually the female. Next. And this is, this is a sign in a hospital here in Arizona. And it's surprising that you don't see more of this, so that patients, when they come into the hospital, they don't feel like, they can get away with murder. Next slide. Same thing goes for gangs. This is a CME course that we had to take at Salinas Hospital, which is the Maginot Line for northern and southern gangs in California, because gang violence doesn't stop at the hospital door. That comes right in. These guys don't care. Next slide. Now, in the case of CARD, you need to know the medical causes of of confusional states, what I call the CDCC complex. Confusion, confusion, dementia, that CDDC complex, states of confusion, altered states of consciousness. Next slide. Another mnemonic for you. Neoplasm. Remember the Texas Tower massacre. That was James Whitmore, who was a military in a special program at University of Texas. He knew that there was something wrong with his brain. This was back in 1966. He was seeing a psychiatrist, but eventually he just gave up because the headaches were getting too bad. He killed his mother. He killed his wife, and then he went up in the tower and started, mowing people down until they killed him. And he was right. He ordered a head and neck autopsy, just like they did with CARD in Maine. But he ordered his own because he knew there was something wrong, and he had cancer of the brain. He had a cancer in the posterior cerebellar area, which is interest is an area that a guy by the name of Robert Heath was stimulating in order to get seriously mentally ill patients out of the hospital. He actually put electrodes in that area of the brain to improve their control. So they blow this off that, oh, well, you can't really attribute the Texas Tower massacre to brain cancer. I disagree. I think you can. Next. Heavy metals, again, we really don't know what, Robert Card, from Maine was exposed to. For those who have been in the military, you tell me, what's a petroleum technician? I mean, what's he exposed to? Next slide. And this is the end. So these are things that you have to be aware of. I told you what, the immediate altered states of consciousness were that needed attention with, immediate These are the altered states of consciousness that can wait 1 hour. So there's a difference between a subdural hematoma, which is a venous bleed in the brain, and an arterial hemorrhage in the brain, which killed Natasha Richardson. You need to know the difference because it's a matter of time. And so these are, again, just the presentations that we need to be aware of. Soft neurological signs, like with Paul Keller, the arsonist. If you went over him carefully, he had some asymmetries in his face that were very subtle. History of psychiatric problems. Kazmierczak, who killed all those people at Northern Illinois University, the psychiatrist who saw him right before he did it didn't know that he had been committed and he had been treated with Clozaril after 3 very serious, lethal suicide attempts in Chicago when he was in high school. He didn't know. Strange behavior. All of these patients that I'm talking about were behaving strangely. All of them were. None of them appeared normal. And some appeared drunk, like Wade Page, who did the Sikh temple murder. And also on the other flip side, the overorganized. That's, that kind of affect where this person is way over controlled and doesn't talk. Policemen have told me that as long as the guy is flapping his mouth, and there is a syndrome, excuse the language, as a paper called the fuck shouter. And in the emergency room, as long as you confine them so they don't disturb the peace, get them some pizza and talk them down, they're not the dangerous ones. Even though they're screaming and yelling, fuck that, they're not the ones that you have to worry about. It's the guy that doesn't look at you, doesn't talk, who's got that flat affect. That's the guy that's going to explode and hurt you. And so that's it.